blood pressure control, both?
Probably the most, it's probably more blood pressure control and dyslipidemia control, but it's hard to separate them because we've been so good at both, you know, over this period of time. So my lecture is talking about hypertension, but statin progress has been tremendous. Of course, there are barriers to statin dissemination, just like there are with all medication, but certainly statins have made a big difference as well. But blood pressure control, I mentioned that you know, the studies show that you do get a 20-25% reduction in MI with the randomized clinical trials. So when we're getting close to 50% here reduction, maybe half is due to blood pressure control, roughly half to you know, hyperlipidemia or dissemination of statins and so forth. So both are important contributors.
Did much better with men than women?
I'm sorry.
The decrease from men was almost 1,500 down to 700, and the women were 800-900 to
Yeah, it's the
700.
men's, the women started almost where the men wound up, you know. So women have a lower,
But less
overall
improvement,
frequency.
but less percent improvement.
Yes. But as I mentioned, for the black population, under age 50 in particular, we have, you know, there's been less improvement there. We have a lot more work to do, and I'm going to address some time about that topic. But there have been positive results over time, and a good portion of that is due to blood pressure success. You know, our smoking rate in Kaiser patients now is under 10%, probably, you know, 8 or 9%. So that's a contributing factor as well. So we'll talk about some of the key elements: hypertension registry, expansion of the medical home with walk-in, no copay, blood pressure checks, and a triage algorithm. We'll talk about regular performance feedback at the team level and the treatment algorithm. So there have been publications. This was the JAMA publication by Mark Jaffe and Joe Young. And Southern California's had a couple of articles. This was in Preventing Chronic Disease, describing the success and the elements of success. So the hypertension registry is important. You have to know, identify the population that you're dealing with. And Kaiser first started developing hypertension registries, I think, with asthma in the late 1990s. And there was success. People, once you know the target group, you're better able to aim your limited resources and develop ways of moving those populations. And so we learned from that. I think there were a couple other registries prior to the development of the California Hypertension Registry in 2000. That was developed in Northern California, and then we adopted it in Southern California a few days later, primarily based upon outpatient diagnostic codes. I forget what the old code was for outpatient diagnosis of hypertension. You had to have 2 codes within 18 months or something like that. That identified about 85% of the registry. Pharmaceutical utilization data, prescriptions for ACE inhibitors, ARBs, or calcium channel blockers, but not beta blockers because those are used in, you know, heart failure and coronary artery disease as well, and some hospital records, discharge diagnoses, and so forth. And so there was a chart review. We found the, you know, sensitivity and specificities of the registry developed with those coding parameters was over 90%. Of interest, our Colorado Kaiser program developed a registry on their own based on blood pressures, going back and having at least a couple of elevated blood pressures within a certain amount of time, a completely different premise. And we, at the national level, we did Venn diagrams. We put our Kaiser Southern California population in the Colorado parameters, and the Colorado population within the Southern California parameters, and we found the overlap was like 98%. So the point is that there are many different ways to develop specifications for your hypertension registry. And if you can do a validation study, then I think that's the basis for utilization. So we've had experience now with our hypertension registry, as you can see, for almost 2 decades. Expansion of the medical home. We all know that we need team-based care, and probably if there are clinical pharmacists here, or you're all familiar with Barry Carter, and Barry Carter has done just a trove of research with pharmacy based teams. There are also Bev Green in Washington, Seattle has done work with nurse-based teams, and so the point is you need a team. And there's a lot of randomized controlled trials to demonstrate efficacy of teams based on primarily, I think, hypertension detection and follow-up program, HDFP, and that led the Cochrane analysis to include, we conclude an organized system of registration we call regular review, aligned to a vigorous step care approach to anti-hypertension drug treatment is the most likely way to improve control of high blood pressure. So based on HDFP, based on Cochrane, there is evidence for this. So we have to have expansion of the medical home, and that's because our hypertension registry in Southern California now includes about 800,000 patients. So we have less than 2,000 primary MDs that take care of, So how can we get 90% control of 800,000 patients with hypertension, with 1,800 doctors? So it's just in your face. We have to do this. And I appreciate Carol's remarks earlier, because we've had trouble, a little bit of difficulty integrating the clinical pharmacist and nurse into the step care approach. They have to go through so many layers of criteria and so forth. So we found our best success is using the medical assistants, the people that check in the patients. And so what we do now is, patients that have elevated blood pressure, that they're seen in primary care, there's an increase in their medication, then they follow up with a walk-in blood pressure check in 2 weeks. And then within their scope of practice, what the medical assistants do is they take a blood pressure. If it's 140/90 or higher, they take a second blood pressure. If the second blood pressure is elevated, there's a triage connection. The primary doctor isn't on site. There's a hypertension doctor who can address the problem at the point of care. And so what the medical assistant does is they identify the elevation, and then they get assistance, and automatically, as part of the protocol, there's 2-week follow-up. So the patients are scheduled for a no copay walk-in blood pressure check in 2 weeks. No matter if nothing is done, if the doc decides that, I think maybe it's it's just a variation today, I'm not going to change your medication, let's see what it is. The patient just doesn't walk out into the clear. They have a scheduled follow-up appointment in 2 weeks. So there's no escape. The other nice thing about the medical assistant blood pressure check is if it's a center for elevated blood pressures outside of primary care. We've done studies that we do blood pressures now at all the surgical clinics, non-primary care areas, urology, neurology, ophthalmology, they do blood pressures. And if those blood pressures are elevated, then the triage is to go to a nurse, to a primary care nurse blood pressure check. So not only are they encompassing primary care, but they receive elevated blood pressures that are taken from elsewhere outside of primary care. So that's beneficial. Incorporating non-primary care blood pressures has increased our identification of hypertension, which I mentioned earlier. Not only do we have to control the patients that we identify with high blood pressure, but we have to go out there and find the patients that have not yet been identified with high blood pressure to bring them into the process. So incorporating non-primary care blood pressures is one way of accomplishing that.
So can I ask a question? So if a patient goes to a neurologist and they identify the patient has high blood pressure, you're saying that from that office, they're sent to a primary care person
Yes.
to double check that same day or 2 weeks later, or how do you, so it's a,
Within
what I hear
2
you
weeks.
saying is within 2
Within
weeks.
2 weeks, yeah.
And it's no referral, no call, you just,
Yeah,
there's
that's
just a
right. So
standing.
they're told, so the clinical assistant will say, you need to get a blood pressure check at your primary care clinic.
And that message goes back to the primary care provider to alert them. So my concern is that you tell them that they have to come back in 2 weeks and then they're going to there.
We used to, there are a couple of processes. We used to have a process whereby they were told just to walk in. But we found that you can't keep track that way. So they need to be scheduled. So they're scheduled for a walk-in blood pressure check.
Before they leave.
Yeah, that's right.
Okay.
What I love about that is the psychological factor saying, this is important. It's so important, you must come back. Because I don't think the clinical system generally emphasizes to patients how deadly this is,
How does it?
how deadly hypertension is. So the
Oh,
fact
yes,
that you're
yes, yes.
scheduling
So
that
basically,
appointment.
the patients get a 2-week follow-up in the blood, until they're less than 140/90. So that's what we do. So it fulfills scope of practice. So this is the way, so we haven't figured out a way to use the clinical pharmacists and nurse practitioners as much, but this seems to work. So provider feedback, the providers always have an inflated opinion of how well they're doing, and so they need real feedback. So we do feedback on a monthly basis, and these are the hospital-based service areas in Southern California. PC is Panorama City, Downey, Antelope Valley, Baldwin Park, San Diego, Orange County, and so forth. And we report these monthly control rates according to administrative data. And then this is done monthly. We have hypertension, our infrastructure is that we have a hypertension champion identified for each hospital-based service area. Orange County now has 600,000 members, San Diego has 700,000 members. Our service areas range from 200,000 to 700,000 members. Each service area has a hypertension champion that gets these results along with their administrative co-champion. So it's not just a physician, it's the administrative co-champion. And then many of the service areas then have hypertension champions at each medical office building within the service area, so it goes down that way. So these reports feed back to physicians, and they feed back to administrators as well. So you can see over 13 or 14 service areas, the spread is from 85 to 88%. And so it's kind of interesting. I think Scott mentioned the principle of competition. And so like in Orange County here is number 7 or something like that. All these emails go flying, we're 7, you know. But you look at it, it's 87 versus 88%, you know. We go up 0.3%, we'll go up 2 positions and 3 positions. So, you know, at the national level, I pointed out the Kaiser regions getting the top 7 spots. The Kaiser regions are competing with each other, you know, to get top 10 ratings. And at this level, there's competition as well.
Do you also use unblinded performance feedback at the physician level?
Yeah, so you're asking a good question. So a lot of it is at the population care level. So the physicians do get feedback at the medical office building, you know, and so they do get the feedback, but they're going to ask for help, saying, what do I do, you know, to improve, you know, because a lot of times these patients are being seen elsewhere and with an elevated blood pressure and so forth. And so, you know, we work with our population care team to outreach to these patients as well. So it's not just enough, you know, giving them the feedback. You have to give them the tools as well. So we'll go into that. But I just wanted to point out that over time, it wasn't always that way. And this was a chart starting from 2005 to 2008. And I pointed out earlier that the transition was between like 2003 or 4 and 2007 or 8. And you can see in the early years, there was tremendous variability. The standard deviation is the red dots, and then performance is the blue dots. So once we started getting real-time data, sharing best practices, and giving that performance feedback, the sharing led to a reduction in standard deviation. So our quality, our performance was in a large part due to control, and a large part due to reduction of variability. So reduction of variability improved our overall performance. And so this is what implementation science is all about. It's different from the randomized clinical trials, you know, where they have a control group and an intervention group. We can't do that when it comes to implementation science. So what we have to do is share best practices and look at our control rate and these other figures, and then, you know, continually learn how to improve. Create a simple treatment algorithm. So you saw the same slide from Scott. When I was national hypertension lead, we developed this algorithm and then disseminated it. So I just wanted to go over it in a little bit more detail. First of all, it has to be evidence-based. We know from JNCA that there's a triumvirate of drug classes and the most evidence-based for results, for reducing stroke and MI rates and so forth. And those 3 groups are thiazide type diuretics, ACE or ARB, and calcium channel blocker. All had showed the primacy of thiazide type diuretic. We know from, and all had also showed the primacy of thiazide type diuretic for our African American population, along with calcium channel blocker. We know we have a lot of unidentified patients with renal disease. We don't do microalbumins on everybody with hypertension. Maybe we should, but we don't. And we know that ACE inhibitors are preferred drugs for treating chronic kidney disease. So this is an algorithm that is very inclusive. It includes African Americans, includes all races, ethnicities. It includes patients with undetected renal disease as well. So it's primarily based on the Prinzide, the old generic lisinopril hydrochlorothiazide combination tablet. And what it's based on is that there are the companies make 3 different strains of lisinopril hydrochlorothiazide that are very confusing. So you have to get the right strain. It's a 20 to 25 milligram tablet. It's not that 10, 12.5 or anything like that. So what we do is we take 1 tablet and we go half to 1 to 2. And that way, in 3 steps, we maximize 2 drugs. So we get our goal dose of hydrochlorothiazide based on the clinical trials is 50 milligrams. Our goal dose of lisinopril based on the clinical trials is 40 milligrams. So that way patients are not throwing out tablets. When you switch them, you can say that, okay, just take a full tablet now instead of a half tablet, and then the refills will say that accordingly. When they go to 2 tablets, they have that same prescription in front of them. So our elderly patients don't have 6 different vials, in their medicine cabinet to confuse. They just have lisinopril hydrochlorothiazide. So this is something that is shown in randomized clinical trials. Stitch trial was a cluster randomized trial in Canada. 90 practice randomized compared sequential add-on monotherapy with first step combination and then add-on. And the 6-month control rate was 65% versus 52%, almost 15% favoring combination therapy. So it works. And our patients, we have limited access. We want them to get controlled in a shorter amount of time. A lot of these patients are higher risk. Scott showed you data, that MIs and so forth decrease within a short amount of time. So this reduces the number of visits. That improves the speed of control. It improves access, and it works. Stitch trial shows that. So simplicity equals performance. This is a primary implementation of guidance principle. It's fewer steps, and it's fewer pills. That improves adherence. It's reduced copays because you're just 1 copay for 2 pills. Faster control, fewer visits. Fewer visits improves access. So the simpler you keep things, the more it works, the more it improves access, the more it reduces copays, the more it improves adherence. So this is a primary principle of this kind of approach.
May I ask you, have you experimented with no co-pays for these medications? Because that's something that one of our other co-chairs, who's now become the head of CDC Cardiovascular, wants to do.
As far as I know, we're still doing copays, though I know there's research into that. It appears that, the $5 copay, is a very cheap generic. That's another advantage of lisinopril hydrochlorothiazide. It's a cheap generic drug. And so that's, of all these drugs, they've been around a long time. They're cheap generic drugs. They're not the latest 4th generation ARB, or anything like that. Prescription rates are associated with hypertension performance. I mentioned in the formative years, 2004, 2008, when our control rates were improving, our lisinopril hydrochlorothiazide prescription rates were also correlated with improved control. Amlodipine is the 3rd drug, calcium channel blocker, and the studies show that edema rates for calcium channel blockers are reduced when other drugs are on board before that, especially ACE or ARB. So it reduces edema when you have other drugs on board, so that's another rationale for this stepwise approach. And based on the pathway trials, spironolactone, the randomized controlled trials with 4 drugs, spironolactone is preferred. And the reason we put those qualifications in green is because this is for primary care. This isn't for specialties. So, and you know, our cardiologists, our endocrinologists, our hypertension specialists will certainly use spironolactone for GFRs less than 60s and so forth. But we want to make sure thiazide is on board because if they get to this step without thiazide, they're going to be on lisinopril. Lisinopril plus spironolactone increases hyperkalemia. So that's the reason. And then we want to make sure that potassium homeostasis is, will allow a drug whose primary side effect is hyperkalemia. So that's why we put those safety parameters on there. And so Tom Frieden and JAMA wrote a commentary of the protocol-based treatment of hypertension, largely based on Kaiser work or reduction of clinical variability, as I showed you, encourages teamwork, cost efficiency, and priority of quality of care. Medication adherence, Hattie asked me to talk about how do you get patients to take these drugs, so I just wanted to spend a few minutes on that. So adherence of at least 80% with prescribed medications is an often used standard for pharmacologic benefit, and now we have all these records, Kaiser doing the MR medication, we feel assistance, or you can just figure out what percent of the time they're picking up their prescription, so you have this information. But there are a few key elements to improve adherence, and one of them starts with the provider. The provider has to have an understanding of medication and messaging. It makes a huge difference. We have to keep patients on these medications for decades. It's not just a few months, it's not just a few years. Hypertension is a chronic condition. So we point out a few things about thiazide. Treatment of mild hypertension study, TOMES, explored 3 quality of life domains. They had multiple questions addressing perception of general health, energy and fatigue, mental health, social contact, social interactions, all these different things. And chlorthalidone, the thiazide representative equal placebo. Alpine study, no difference in sexual satisfaction, thiazide versus candesartan, which comes up. SHEPS, systolic hypertension, the elderly program, showed sexual problems, thirst, nocturia, chlorthalidone equals placebo. So what about thirst and nocturia? Does that make sense? Frequency of adverse side effects, hydrochlorothiazide versus placebo, abnormal urination, the same. But wait a second, thiazide is a diuretic. Aren't we going to tell our patients they're going to pee more? Well, you have to understand the physiology a little bit. If you look at blood pressure and physiologic parameters with initiation of diuretic therapy, you can see that there's an initial reduction in fluid volume, but over time, fluid volume gets close to baseline, and the main benefit is peripheral resistance reduction. So thiazide diuretics primarily reduce peripheral resistance. That's the way they work, and that's why we don't message patients that urination is going to be a problem. What we do tell patients, and we have to tell them about side effects. When I put a patient on thiazide, I said, the side effects of this have to do with sodium and potassium. We're going to do a blood test in a week or two after you've been on this medication, so we can assess that. And that's another beauty of the lisinopril hydrochlorothiazide combination, because there are balanced effects on those electrolytes. But if you message patients a certain way, there is a nocebo effect that you have to be careful of. And a lot of our patients are drinking 8 glasses of water a day, and that's going to cause a lot of urination. Dear Dr. Handler, again I request the road pill to replace amlodipine to eliminate the swelling of my ankles. Please